finished my medical school training actually here in Jordan University of Science and Technology. And then I pursued my surgical training in the States. I finished my surgical residency at St. Agnes Hospital, Baltimore, Maryland. And then did my laparoscopic and bariatric fellowship training in University of California, San Francisco, the Fresno campus, with Dr. Calvin Higa and Dr. Keith Boone. They're both world-renowned bariatric surgeons and minimally invasive surgeons. And then after finishing my fellowship, I came back to Jordan. I've been here since August of 2010. Here we do all the bariatric procedures. The laparoscopic Roux-en-Y gastric bypass, which is the oldest procedure for obesity, and the sleeve gastrectomy, the laparoscopic adjustable gastric band, some revisions, as well as some of the newer procedures like gastric. Application actually is a procedure that does not require any stapling, any cutting of any part of the stomach. It's almost like forming a sleeve from the stomach itself by just folding it through sutures. So there's no cutting. Some say that would take away the risk of leak, although a lot of the experiences out there, the new experiences, do not support that yet. The weight loss has been, though, good. The need for additional procedures, endoscopies, and these things are still there. I think the procedure is still in evolution right now. So I can't really tell you if it's good or bad. We still need further data. That's why I'm willing to go that route if the patient is willing as well. Which is definitely the most superior in obtaining weight loss. It's superior to the gastric bypass itself. It's usually done in 2 stages, and we usually reserve it to the super obese patient population. That means the body mass above 50, and definitely patient population for the body mass above 60. The procedure is separated into basically the sleeve gastrectomy portion, and bypassing the second, third, and fourth portion of the duodenum, almost bypassing 50% of the small bowel itself. So it has a restrictive component and a malabsorptive component. That's why it has a superior result to the gastric bypass. Even long-term wise, weight regain is not that common with the duodenal switch itself. And it's a superior procedure in diabetes remission as well. So if that patient who has severe significant diabetes, insulin dependent for a long time, you probably would have a better result with the duodenal switch as opposed to the gastric bypass. The one drawback is the drawback of the sleeve gastrectomy, which is reflux. It does not treat reflux. So in those patient population, you're probably obliged to do a gastric bypass instead of the duodenal switch. Non-surgical option for weight loss. It's done through endoscopy, basically placing a balloon that takes a good sized portion of the stomach volume and reduces the amount of food that you eat. And it's taken out after 6 months, so it's almost like a forced 6-month diet. The one patient population that I would not advise to have a balloon is those patients who have severe heartburn or reflux, because it's going to make it much worse. It does not have a great outcome in the morbidly obese patient population, the average weight loss is about 26% of the excess body weight loss. And it definitely needs a commitment from the patient as well to achieve great results. Once it's taken out, the majority of the patients though tend to regain the weight back. So the patient population who are obese but do not fulfill the, let's say, the criteria for morbid obesity, like the NIH criteria that we go by, or the patient population who are severely obese who cannot undergo an operation just because of their medical problems. Those are the patient population that I really advise the balloon for.